everyone. Welcome to our next session, How Doctors Decide How to Treat Your Cancer. My name is Alex Sanders, and I'm an oncology nurse coordinator at Roswell Park Comprehensive Cancer Center in Buffalo, New York. At most cancer centers, a multidisciplinary clinical team meets regularly to discuss challenging or unusual cancer cases at a meeting sometimes called a tumor board. The goal of these meetings is to bring all of the experts into one room together to make recommendations on how to best treat a patient. A meeting that reviews kidney cancer cases may consist of doctors like medical oncologists, urologic oncologists, radiation oncologists, interventional radiologists, pathologists, and other clinicians like genetic experts, nurses, pharmacists, and clinical trial coordinators. We thought today would be a great opportunity to simulate discussions where our panel will review 4 cases and provide insight into why they would recommend a specific treatment option for that scenario. Hopefully, this gives you a behind-the-scenes look into how doctors collaborate with each other to treat patients with kidney cancer. I am joined with several kidney cancer experts. Let's go around and have each panelist briefly introduce themselves. Let's start with Dr. McKay.
It's a pleasure to be here with you all. My name is Raina McKay. I'm a GU medical oncologist at the University of California in San Diego.
Thank you so much. And Dr. Fitzgerald?
Hi, thank you for having me. Kelly Fitzgerald. I'm a genitourinary medical oncologist at the University of California in San Francisco.
Thank you. Dr. Hanan?
Rakibul Hanan. I'm a radiation oncologist. I specialize in treating kidney cancer with stereotactic radiation. I'm from UT Southwestern.
Thank you. Julia Stevens?
Good afternoon. My name is Julia Stevens. I'm a medical oncology pharmacy specialist at Beth Israel Deaconess in Boston.
Thank you. Dr. Shuck?
Hi, Brian Shuck, a urologist at UCLA.
Thank you. Dr. Gordetsky?
Hi, Jennifer Gordetsky. I'm the medical director of anatomic pathology at Vanderbilt University Medical Center. I specialize in genitourinary malignancies.
Thank you. Dr. Kim?
Yeah, my name is Dr. Jung. Thank you for having me today. My name is Sung Kim, interventional radiologist from UT Southwestern Medical Center. I'm specialized in interventional oncology, especially kidney cancer treatment.
Thank you. And Dr. Sutka?
Hi, everyone. Thank you so much for having me. My name is Sarah Sutka. I'm a urologist at the University of Washington and the Fred Hutch Cancer Center.
Amazing. Thank you so much to all of our panelists. Let's get started with our first case. Our first case looks at Robert, a 63-year-old man. His doctor found a 3.5 centimeter mass on his right kidney after he had an X-ray for an unrelated medical condition. Robert's primary care doctor referred him to a urologist. Dr. Shuck, if you were seeing Robert in your clinic, what are the possible diagnoses for the mass?
Well, I would first get, proper imaging study, which is a CT or MRI, and X-ray is not really used. But a renal mass that takes up contrast is a tumor, and a tumor can be benign or it can be malignant, meaning it can have the ability to potentially spread, aka a cancer.
Thank you. And what type of imaging would be done to assess the mass?
So usually do a scan with and without contrast, and it's either an MRI or a CT, which would be the first choice.
Great. And another question, would there be a reason to biopsy the mass at this time?
So a biopsy would be done in a patient where you think it's going to change management. If a patient has a tumor, which enhances, we occasionally offer a biopsy if we feel like it's going to change the patient's treatment decisions. And if someone is very young and doesn't care what it is and wants it out, there wouldn't be any indication. If someone's older, sicker, frailer, and probably would watch it, you would probably think there's a limited role in a biopsy there.
Awesome. And 2 follow-up questions to that. What type of biopsy would be used for kidney masses, and what type of doctor would do that biopsy?
So a core biopsy with a needle, not a tiny needle called an F&A. You want to get a piece of tissue where the pathologist can look at it under the microscope. Most biopsies are done by interventional radiologists. There are a couple of urologists that do them under ultrasound, but for the most in the United States, it's under CT or ultrasound in a radiology suite.
Thank you so much. Moving on to the next slide. Robert had a CT of the abdomen with contrast and without contrast. The CT showed that the mass was a Bosniak 3 cyst. Bosniak cysts range from type 1 to type 4. Dr. Shuck, what's the difference between a Bosniak 1 cyst compared to a Bosniak 3 or 4 cyst?
So Dr. Bosniak developed a scale to basically risk stratify cysts, so we can understand which ones pose risk to the patient. And a simple cyst with water is a Bosniak 1 cyst, and those are not treated unless they get very, very large and cause symptoms. Something that's a Bosniak 3 would have cystic septations or dividers. They could be thickened. There could be some tiny mural nodules that are small. They can have some uptake of a contrast in the walls of the septations. And that one would have a little bit more risk, maybe a 40 to 50% chance of having a cancer.
Thank you so much. Moving on to the next slide, there are several possible treatment options for a Bosniak cyst. Dr. Shuck, when would you recommend a watch and wait or an active surveillance approach?
So in someone who has a Bosniak 3 renal lesion, which again has a risk of cancer, but usually they're not very aggressive or rapidly growing, anyone who's older, 60 and above, I think it's a very reasonable approach to just continue observation. Unfortunately, with that type of cyst, you can never stop observing because there's always going to be concern. But a younger, healthier person who doesn't want to follow it the rest of their life, that would not be an option if they had anxiety or they were very young.
And Dr. Shuck, when would you recommend surgery?
If someone wanted to have surgery to have it removed and looked at pathologically, I think that's a good option. Again, most of these are fairly indolent. They don't really grow very rapidly. Most of them really have low risk or low metastatic potential, but they can occasionally be aggressive. And a surgery to remove it, you'd understand what it is. And if it was benign, you wouldn't need any follow-up. If it was cancer, you'd potentially be able to survey it.
Thank you. Dr. Kim, is ablation therapy an option for a Bosniak cyst like Robert has?
I think as Dr. Shaw mentioned that it depends on Bosniak type, and then definitely there is a solid component of imaging, CT or MR imaging, and then we can do ablation. There's a little bit of a chance of rupture during the cyst. Sometimes we can put a tiny needle, aspirate the cyst, and then we can ablate using either these days either microwave or cryoablation. We're able to focus on the main solid component of a nodule. And then technically it's not much difficult procedure for us to do. We can mainly use CT guidance with the totally general anesthesia, and the procedure time is up to 20 hours. After procedure done, we recommend 3 to 6 months follow imaging and go from there.
Thank you. Dr. Hanan, what about radiation therapy? Is that a possibility to treat a Bosniak cyst?
Yes, so if treatment is indicated and patient is not a surgical candidate for comorbidities, age, and other issues, stereotactic radiation is completely non-invasive. It can be done in as low as a single treatment, and the patient's daily life would not be affected otherwise. So yes, it would be an option at that time.
Thank you so much. So Robert decided that he'd prefer to watch and wait to see if the cyst would change or get larger over time. He had a CT scan every 4 to 6 months for the next 2.5 years. During that time, the cyst grew in size until it was about 5 centimeters. It also continued to develop additional solid material, which concerned Robert's doctor. The doctor recommended a partial nephrectomy. The pathology of the cyst showed that it was clear cell renal cell carcinoma. Dr. Gordetsky, can you talk about the pathology of clear cell RCC, and how can you tell that it is clear cell compared to another kidney cancer type?
So clear cell renal cell carcinoma is the most common histologic type of renal cell carcinomas. A renal cell, I guess to take a step backwards, a renal cell carcinoma is a malignant tumor that comes from the kidney parenchyma, or the fleshy part of the kidney, as opposed to the collecting system where the urine would go down. So the clear cell, we call it clear cell renal cell carcinoma, and you can kind of see it in the picture here. It's just because there's clear cytoplasm, so the nucleus you can see pretty well, and then there's a lot of clearing around it. And so that's where the name comes from. And as I said, it's the most common type of kidney cancer.
Dr. Grodetsky, can you talk a little bit about what grade 3 means and how does it impact future recommendations?
Right. So we grade these tumors actually based on the detail of the nucleolus, which is a part of the cell that we see under the microscope. And so basically the idea is that the smaller that part of the cell is, the better the prognosis, and the larger it gets, the higher the grade. And you can have grades 1 through 4. 1 is the best prognosis, and 4 would be the worst. I think, a grade 3 tumor is, obviously a higher grade tumor, but I think in of itself, it wouldn't necessarily impact management. I think it's just one of the many prognostic features that you look at when you think about disease recurrence and progression and that kind of thing.
Thank you. Dr. Shuck, what kind of follow-up care does Robert need to monitor for Bosniak cysts in the future?
So you need surveillance anytime you have cancer removed from your body, and depending on how aggressive it is, you would dictate the surveillance frequency and the imaging modality type. But we're not really worried about a simple cyst, a Bosniak 1 cyst. Those rarely are ones that will ever change. They can get larger and smaller. But you're going to do surveillance here just for looking for cancer recurrence, either locally or distantly. The risk here would be low. It would probably be about 5% lifetime risk for a T1B tumor.
Thank you. That concludes our first case. We'll move on to our next case with Sandy, a 59-year-old female who is having pain on her side off and on for several months. She could usually get relief using over-the-counter medications and other home remedies. However, she went to the emergency room one evening when the pain became constant, and she couldn't get any pain relief at home. The emergency room was concerned with an untreated bladder or kidney infection, and a CT scan of her abdomen and pelvis was ordered. The CT scan showed a 7-centimeter mass on her left kidney that was thought to be a stage 2 renal cell carcinoma. For stage 2 renal cell carcinoma, surgery is usually recommended per guidelines from the National Comprehensive Cancer Network, or NCCN. The guidelines are used by physicians across the country and across the world to provide evidence-based kidney cancer care guidance. Dr. Sutka, what kind of nephrectomy is a better option for Sandy? Does the size of the mass or her age play a role in the type of nephrectomy that you would recommend?
So for a stage 2 kidney cancer, we can do a partial nephrectomy or a radical nephrectomy. Partial nephrectomy is essentially cutting the tumor out and saving the rest of the kidney. A radical nephrectomy is the removal of the entire kidney with all of the tissue that surrounds it, because our kidneys are invested in sort of the fat that sits in the back of our body. The things that help us make a decision between doing a partial versus a radical are the size of the tumor, where it's located within the kidney, and how close it is to the blood vessels of the kidney. If it's really central and it's a larger mass, it's harder to take that out and preserve the kidney and its blood supply. If it's on either of the top or the bottom, it's easier to do a partial nephrectomy. The other things that make a big difference are whether or not the patient has a normal kidney on the other side. If her kidney function is normal, so she would be okay with just one kidney. And then also if she has any medical conditions that might threaten her kidney function in the future. So we're always thinking about how can we remove the tumor safely and get an oncologically good result, which means we get the whole cancer out safely, but also preserve as much kidney function as possible so that patient has a very low risk or as low a risk as possible of going on, for example, dialysis in the future, of needing dialysis. So here, depending on where the tumor was, if this patient has a totally normal renal function, she could potentially have one kidney removed. But here, it's all about sort of weighing the risk of potential renal dysfunction against making sure we can get a safe operation done.
Sandy's doctor recommended a partial nephrectomy. There are different ways to perform a partial nephrectomy. Dr. Sutka, can you briefly explain each option and the situation in which each might be recommended?
Certainly. So we can approach the kidney a number of different ways. We can do this through an open incision that can be done either on the flank or the side, just underneath the ribs, or it can also be approached from the front. And then we can also do this through a minimally invasive approach, either laparoscopically, which is where the doctor holds instruments that are inserted through small trocars, through tiny poke holes, and then the specimen is removed through one of those, which is extended slightly. Or in a robotic-assisted minimally invasive approach, there's a robot that holds the instruments, but a surgeon is still controlling them and doing that operation. The decision-making between choosing an open versus a minimally invasive approach includes consideration of the patient's prior surgical history, whether or not we expect that they've had lots of surgery on their belly before, and we are expecting to encounter a fair amount of scar tissue. We're looking at their body habitus. We're looking at where the tumor is, if it's on the front of the kidney and we need to come from the front, or whether it's on the back of the kidney and we actually need to be thinking about what's called a retroperitoneal approach. And I think also we do consider things like recovery. So the smaller the incision, the recovery is a little bit faster, but there are lots of things that we can do even with a big incision to help patients recover quickly. So we really try to choose the approach that's best for both the patient and the tumor.
Thank you. For this case, is there a right or best technique for Sandy?
There really isn't. We don't know anything really about her surgical history, but I think in this situation, it also would depend on the provider's experience and their comfort with what is a larger tumor. Doing a partial nephrectomy, if we're trying to do a partial nephrectomy for a 7-centimeter tumor, sometimes that is, depending on where it is, more easily accomplished through an open approach versus a robotic approach. Generally these days, I think most providers choose between either an open approach and a robotically assisted minimally invasive approach.
And for each of these options, what does the recovery look like?
For the minimally invasive surgeries, most patients are in the hospital for 1 to 2 nights and then go home. And then we say, I generally still tell patients it's sort of 6 weeks of no heavy lifting and kind of recovery time. However, generally with the minimally invasive approach, the recovery is a little bit faster. With an open approach, patients are in the hospital anywhere between 2 and 4 nights, I would say, depending on a flank versus an incision on the front of the belly. And then, like I said, we do also have to give them time to recover before they do any kind of aggressive exercise or activity, because we don't want them to develop any kinds of hernias. We want everything to heal nicely.
While Sandy had a partial nephrectomy, there may be non-surgical options that could be used to treat the mass on Sandy's kidney. Dr. Hanan, could radiation be used in this case?
I think so. They would again depend on the specific location of the tumor. So just like Dr. Sutka was saying, for surgery, certain locations are preferable. For SBRT, stereotactic radiation, certain other locations are preferable. So while a tumor that's in the middle of the kidney near the blood vessels and the center is not a problem for radiation, but if you have a 7-centimeter tumor that's located anteriorly where it's coming in contact with a lot of the small bowel, that could become difficult for stereotactic radiation. But for the most other locations, we have treated large kidney tumors and we have shown a local control rates of 90%. So again, depending on the location of this tumor, I would say stereotactic radiation would be an option.
Thank you. And can you explain a little bit more about SBRT?
Absolutely. So stereotactic radiation, it starts with a planning session where we make that mold for the patient that you're seeing here. We sometimes give contrast, sometimes we can even do an MRI. We see how the kidney tumor is moving with the breathing, So all of that mapping takes about an hour. After that, we take 1 to 2 weeks to plan the radiation, and then patient would come in. For smaller tumors, we can treat it in one session. Each of the sessions would be where we put the patient back into a mold like this and just a machine like this that is usually open. Takes about 30 to 45 minutes. There is no recovery from radiation, so patient can do whatever they're doing in the daily life and come in and get the radiation and then go back to doing what they were doing. For a larger tumor like this, 7 centimeters, it may take 3 or 5 sessions like this. Side effects typically are transient nausea in the short term. In the long term, again, there could be some decline in the kidney function compared to surgery. But that's in general what it looks like.
Thank you. Dr. Kim, what about ablation therapy? Could radiofrequency ablation or cryoablation or even both options be used?
I think usually we used to start with the radiofrequency ablation, and then we switched to microwave ablation or cryoablation in the most United States institution. And usually is tumor is less than 3 centimeters is very great for the radiofrequency ablation, cryoablation, but tumors getting bigger, this case is 7 centimeters is, not used to get enough, not used to do entire tumor easily with the ablation. It depends on location because tumor is very central location. It's not easy for ablation, but if the tumor is exopenic, is growing outside, we can try to do, especially is my practice, I usually do embolization, meaning we try to decrease the blood supply to tumor, and then we try to shrink the tumor, and then we can put the needle on the CT guidance, and then it depends on tumor location. If the tumor is a good location for ablation, we might be able to do ablation for these patients. But 7 centimeters is a bit big for ablation. We can do around the 4-5 centimeters. We can easily do ablation with the combination with the embolization procedure.
Thank you, Dr. Kim. The pathology from the tumor removed during surgery showed that it was clear cell renal cell carcinoma with sarcomatoid features. Dr. Grodetsky, we talked about clear cell RCC in the last case, but can you talk more about how having sarcomatoid features might change a prognosis?
Sure. So when you look at the picture that's here, you can see that some of the cells have white spaces around them, and that's how we know that this is a clear cell renal cell carcinoma. When we talk about sarcomatoid features, what we mean is that some of the cells have become spindled or elongated. And that is a poor prognostic feature in the tumor. It means it's more aggressive. It means it's more likely to metastasize. Or if you have a partial nephrectomy, it's more likely to have disease recurrence. So it's just associated with worse outcomes.
And regarding the pathology information provided, what does the pathology stage mean?
So in this case, it's a T3A, and what that means is that the tumor has grown outside of the kidney. So for stage 1 and stage 2, the tumor is confined within the kidney, and the stage is basically based on size of the tumor. Once you hit stage 3, that means the tumor has somehow escaped the kidney, and that could be done through several ways. It could extend into the fatty tissues on the outside of the kidney. It could invade the large vessels, the blood supply to the kidney, or it can invade the collecting system where where you would typically have the urine go. And so if the tumor has escaped either into where the urine is collected, the collecting system, or into the tissues around the kidney, or into the big blood supply vessels that supply the kidney, all that would be considered stage 3.
Thank you, Dr. Grodetsky. The treatment guidelines recommend that for stage 2 clear cell RCC with sarcomatoid features, additional treatment after surgery may be recommended. Dr. Sutka, what would no additional treatment with routine monitoring be a good option for Sandy?
Well, it certainly can be. The monitoring is much closer in this situation. So we generally follow patients with CT scans or MRIs of their abdomen and pelvis, and also imaging of their chest every 3 months for the first couple of years. And then it spaces out as we get further and further away from surgery. But we do have to understand that with the grade 4 sarcomatoid differentiation, and this patient actually has stage 3A disease, her risk of recurrence, this is considered a locally advanced tumor, so her risk of recurrence approaches 50%. And so that would be one of the reasons why I would have a conversation with my colleagues from medical oncology about whether or not this patient would be a candidate for adjuvant immunotherapy.
Thank you. Dr. Fitzgerald, if medication is needed adjuvantly or after surgery, would pembrolizumab, also called Keytruda, be recommended for Sandy? And could you tell us a little bit more about pembrolizumab?
Yeah, so Keytruda or pembrolizumab should absolutely be considered for this patient. We had an FDA approval for this drug in 2021 for use in the adjuvant setting in kidney cancer, meaning given after surgery to increase the likelihood of a cure. This was approved based on the results of a clinical trial where they tested 1 year of Keytruda versus 1 year of a placebo in hundreds of patients who had kidney cancer that was a high risk of recurrence, like what we see in this patient. She would absolutely be considered at high risk given the T stage and the presence of sarcomatoid features. So it is something that definitely should be considered for her. It is worth acknowledging when you're considering using an adjuvant treatment of any kind, including pembrolizumab for patients, that many patients can do well with surveillance alone, again, depending on characteristics of their disease. And it's also important to take into account the potential for side effects from treatment. So it really is a very individualized decision between each patient and their oncologist as to whether to enter into this.
Thank you so much. Additionally, Dr. Fitzgerald, can you talk a little bit more about pembrolizumab in terms of how often is it given after surgery for stage 2 RCC, and how many treatments would Sandy need to receive?
So there's really 2 dosing regimens that would be considered clinically appropriate and reasonable for use. Probably the more common approach is to be giving infusions every 6 weeks at a dose of 400 milligrams up to a year, so 9 treatments in total. That being said, it is reasonable and considered clinically equivalent to be giving this every 3 weeks as well at a dose of 200 milligrams, and that is really up to the comfort of the patient, the oncologist, and preference.
Thank you, Dr. Fitzgerald. Dr. Stevens, what are the possible side effects Sandy may experience when receiving an immunotherapy medication like Keytruda?
Sure. Well, first, I'd like to say that most people feel pretty well when they're on pembrolizumab beyond maybe some mild fatigue. However, about a third of patients will experience what we call immune-related side effects, which is basically we've revved up the immune system so it can recognize any remaining cancer, but it can also then go attack other organs. So the most common immune side effects are diarrhea or colitis, rash, and high or low thyroid. However, the immune system can attack pretty much any organ, although it's rare for other organs to be involved. The other important thing to know is these side effects are typically delayed at least a cycle or 2 or a month or 2 into therapy, although they can present earlier or later, even after stopping the drug. Some patients will require steroids to help reverse these, although some don't necessarily require steroids. It's also possible that patients may require long-term hormone therapy supplementation, such as levothyroxine for hypothyroidism, that may require lifelong supplementation.
Thank you so much, Dr. Stevens. That wraps up our second case. Our next case follows Eddie, a 48-year-old man with a history of bladder stones. He usually had blood in his urine whenever he had bladder stones, so he wasn't concerned at first. But when he started having a different type of pain than he usually has with bladder stones, he saw his urologist, who ordered a CT of his abdomen and pelvis. The CT showed that there was a 10-centimeter mass on Eddie's right kidney that extended into his renal vein. Dr. Sutka, in this scenario, the patient's tumor was only extending into the renal vein, which is shown in the top left image. but sometimes the tumor can extend past the renal vein. Can you explain what we're seeing in these examples and how would this mass be staged?
Certainly. So this is something that's really unique to kidney cancer, which is that it's one of the few tumors that has the ability and the propensity for growing into the veins that are draining the organ. So veins take blood away from an organ. Kidney cancer, about 10% of them will grow into the veins. We grade, or we sort of make a commentary to characterize the degree to which the veins are involved using the staging system that you have in front of you. So a tumor that just goes into the renal vein is a level 0. If it goes into the inferior vena cava, which is the big vein in the back of the body that drains all the blood back up to the heart, but it's only within 2 centimeters of where the vein contacts the IVC, that's a level 1. If it's above 2 centimeters, but below what are called the confluence of the hepatic veins, which those 3 venous structures that are kind of in the middle of the liver that you see up there, that's a level 2. And then between the hepatic veins and the diaphragm is a level 3, and above the diaphragm is a level 4. The reason this is important is it helps us as a surgeon prepare and understand what we might need to do in order to safely remove the tumor during surgery, what other team members we might need to have available, because obviously the operation becomes much more complex when we're removing one of these veins, because it's also a vascular procedure that can sometimes involve either vascular surgeons or our colleagues from hepatobiliary and transplant surgery, or obviously if the tumor is above the diaphragm and in the chest, we will often involve cardiothoracic surgery. We often need a different anesthesia team when we're preparing for one of these cases, such as cardiac anesthesia. And we may also need what's called a perfusionist, who is someone who can help us, because when we're doing this, we have to temporarily stop the blood flowing through all of these vessels in order to open the vessels and remove the tumor. We might need some ability for us to basically have blood go outside of the patient's body from below where the tumor is back up to the heart. And so the surgical preparation for one of these cases is much different. They're generally only done in centers that have a lot of experience doing them. They tend to be more academic centers than centers that also have hepatobiliary, transplant, vascular, and cardiothoracic surgery ability. And also, we also, when we talk to patients about this, have a conversation about sort of a slightly different and oftentimes more extended recovery that might include recovery within an intensive care unit in some circumstances, and also just a longer recovery in general.
Thank you. Dr. Sutka, is a radical or partial nephrectomy the better option for Eddie with this case?
So this is a much larger tumor, and it's a much more extensive tumor with venous involvement. Generally, we only consider partial nephrectomies when there's venous tumor thrombus like this in very rare circumstances where it's mandatory to keep a patient off of dialysis. But in general here, it's oftentimes much harder to do an oncologically safe procedure and make sure we get it all in doing a partial nephrectomy. So generally a radical nephrectomy is the preferred option when we have a venous tumor thrombus like this, except in very rare circumstances.
Thank you so much. Dr. Hanan, is there any role for radiation in this case?
So the role for radiation in this case is really investigational. We have published a number of case reports. We have completed a phase 2 trial, but we have not, it has not matured to be published yet. But basically, a number of case scenarios where radiation could be applied. Of course, first one is if the patient just is not a surgical candidate, then we will do what we can with the larger tumors, and we have reported up to 60 to 70% response rate in this setting. But another setting could be if the thrombus is level 3 or higher, and it did block those hepatic veins, and now there is venous congestion, that really becomes a much higher risk surgery. And in that setting, we have treated a few patients to the thrombus with high-dose stereotactic radiation, waited 3 to 4 months, and the tumor regressed and the venous congestion resolved, and then the patient became a surgical candidate and underwent surgery safely. A third setting could be that patient is just not a candidate for this extensive surgery, but is a candidate for a rather easier radical nephrectomy. And in that setting, a couple of cases, we have treated the thrombus with stereotactic radiation, and the patient had a radical nephrectomy. And lastly, rarely there is positive surgical margins where the tumor thrombus is invading into the vein, And if the tumor returns there, we have treated those with stereotactic radiation. So a number of roles possible, but they are investigational at this stage.
Thank you. And Dr. Kim, what about ablation therapy?
Actually, the patient is not a candidate for ablation. The tumor is too big and extends the renal vein. And the part of some of the interventional procedure I mentioned about that is embolized procedure. It also is kind of a clinical trial things going, and then we can the kidney tumor has a lot of blood supply, and then we can get into kidney artery, and then we can inject some of the embolic agent plus some of chemotherapy, and then before surgery we can decrease the blood loss during the surgery, or combination with immunotherapy or chemotherapy, just we try to shrink the tumor and then hope that make a patient can be a candidate in the future nephrectomy or kind of things.
Thank you, Dr. Kim. So Eddie's doctor performed a radical nephrectomy. A few questions for Dr. Shuck. First, what considerations are needed during surgery when the tumor has spread into the renal vein?
So again, when something is moved into the renal vein, it's the largest vein in the body. And if you're going to need to, if it's just in the renal vein, you might be able to basically staple off the renal vein before it gets to the vena cava. But if it's in the vena cava, you really need to know, is it, what level does it go up to? As Sarah said, if it's above a certain level, what team you need to assemble. You also want to know if there are any what we call bland thrombus or like a normal blood clot that goes below. Because if that's the case and you remove all the tumor, you don't want to leave all that normal blood clot behind. And we sometimes would do what's called the interruption of the vena cava. But this is generally going to be only the first step in someone's treatment plan. And it's very important to again begin the discussion about, a surgery may not be enough, because patients are going to have a risk of recurrence. And we like to begin the discussion of adjuvant therapy, early on in the discussions.
What is the recovery like after a radical nephrectomy?
So with a regular radical nephrectomy, where we can do it minimally invasively, it's usually a one-night hospital stay. We have been doing some of these very small level thrombuses that are just poking in the IVC. We can consider them done robotically as well. But when we need to do an open operation, very large tumors, maybe pushing or invading into other organs, or we need to really make a large incision to take out a very high level IVC thrombus, we're talking probably anywhere from 3 to 5 days in the hospital, waiting for pain control and waiting for patients to recover their bowel function. So that's probably a little bit longer in the hospital stay and a little bit longer recovery functionally.
Thank you. And for Eddie, moving forward, are there any special considerations because now he only has one kidney?
So there's plenty of patients who have one kidney and have very good kidney function, and they do not need to change their diet. We know that patients who have what we call chronic kidney disease, where their kidney function starts to decline, they need to often see a nephrologist. They need to have very good control of their blood pressure, their weight, their sugars, and they should exercise. But just because you have one kidney doesn't necessarily mean you need to take dietary modifications. It depends on the creatinine, someone's comorbidities, and hopefully we can get them through with a normal, healthy life with one kidney. But if they have compromise or at risk of compromise, they really need to be careful and really get plugged in with the right medical team.
Thank you so much. The pathology showed that the mass was chromophobe renal cell carcinoma. Dr. Grodetsky, how does chromophobe RCC differ than clear cell or another type of RCC under the microscope?
So compared to the clear cell renal cell carcinomas, chromophobes are much more pink looking tumors. They also have this classic feature where there is clearing around the nuclei. We call that a perinuclear halo. These tumors actually tend to be not as aggressive as clear cell renal cell carcinomas, and they're certainly much less common than clear cell renal cell carcinomas, but about 5% of them will show aggressive behavior and metastasize. So in this case, the tumor has spread to one of the lymph nodes, Then that's why, if you look at the pathologic stage, it says 3A, indicating that there was spread outside of the kidney. In this case, it was into the renal vein, and N1, meaning that one of the lymph nodes has metastatic disease, meaning the tumor has gone into the vasculature or the lymphatics and has made its way into the lymph node.
And with that, how does the involvement of the lymph node impact the diagnosis?
It just means that, again, it's a prognostic indicator. It means that this person no longer has regional disease, meaning that the tumor is not confined to the kidney, and it has metastasized. And so the prognosis, the diagnosis is the same, but the prognosis is much, much worse.
Thank you, Dr. Brodetsky. The guidelines indicate that for stage 3 RCC, if the cancer is not clear cell, additional treatment may not be needed, but a clinical trial could be considered if appropriate. Dr. Shupp, would surveillance and no additional treatment be a good option for Eddie given the situation?
So this patient is going to have a very high risk of recurrence. It is rare to have chromophobe tumors invade into the renal vein and IVC, but it can happen. This patient probably has a 50, or greater % chance of recurrence. The problem is we don't have much data with adjuvant therapy with chromophobe. We don't have great data with response to chromophobe in metastatic settings to immunotherapy. So yes, you probably could, give them adjuvant therapy, but there's not much data supporting that role. If there was an available trial, which I don't think there are, many open now for this setting, it would be very good to get that patient considered. So yes, this patient needs to be watched extremely closely and discussed in a multidisciplinary manner, but unfortunately, we don't have any strong evidence that we can really lower the risk of recurrence at this time.
Thank you so much. Dr. McKay, are there any current clinical trials that might be a good option for Eddie?
There are some clinical trials that are currently ongoing, though these clinical trials are largely restricted for patients that have clear cell RCC. We don't have an adjuvant clinical trial right now that is currently enrolling individuals who have chromophobe RCC, who've been resected and are at risk of recurrence. These clinical trials, the adjuvant V940 trial is a microRNA vaccine study with pembrolizumab for patients with RCC that are high risk post-resection. And the Alliance Cooperative Group is designing a study called the STRIKE trial of adjuvant nivolumab plus tivozanib. This study has been approved and will be activated, within the next year. But these studies, I think, are largely for individuals that have clear cell RCC. I think the treatment of patients with non-clear cell histologies in the localized setting remains an unmet need. There is a adjuvant study being planned for papillary RCC, but for other pretty rare histologies, the data are quite limited.
Thank you, Dr. McKay. Our final case for today follows Howard, a 57-year-old male who was suddenly feeling unwell and went to the emergency room. He was having trouble breathing, and so a CT scan of his chest was ordered that showed a blood clot in his lung. To make sure there weren't other clots, additional scans were done that showed a 5-centimeter mass on his left kidney and other spots on his lung, thigh bone, and lymph nodes. Howard has several spots that could be cancer, and it's not known if the cancer is kidney cancer or another cancer. Dr. Kim, as an interventional radiologist, is there a preferred spot to biopsy?
I think it depends on, but it usually, referring physician, it depends on, but we can do either they want to check the metastasis, we can do lung, or sometimes we can do both, kidney, lung, bone at the same time. But usually, that we try to get each one. Sometimes, lung node is too small, not easy, because for example, one same node is not easy to get a biopsy. Sometimes it prefer to kidney tumor, but I think this goal of care is metastasis. That's why we need to target lung or bone or lymph node. It depends on each location. CT guidance. Usually we use, but it depends on location. It's a bigger one. Is they want to just check the metastasis, or just want to get the primary. But usually in this scenario, and they don't want to get the primary tumor biopsy, they prefer the metastasis. They want to check the metastasis or not. That's why we try to get easy one. Easy one is less risk of biopsy.
So Howard did have his lung mass biopsied, and it showed that it was papillary RCC. Dr. Grodetsky, since the lung mass was biopsied, how would you know it's renal cell carcinoma instead of lung cancer or another cancer?
Yeah, that's a great question. So when we have ancillary testing we can do, so when we look at a tumor just with this pink and purple stain you see here, which is called hematoxylin and we can tell certain features, in this case that it has papillae, but lots of tumors can make papillae or be papillary, including lung cancers, thyroid cancers, cancers from the ovary, cancers from the uterus. So part of it is what is the gender of the patient. The other part of it is using ancillary testing. So there are different types of stains we can use, and we can see if the tumor cells are positive for different markers, and those markers help indicate where the tumor is coming from.
Thank you, Dr. Grodetsky. Because the cancer has spread outside of the kidney to other parts of the body, Howard has metastatic kidney cancer. Let's take a look at the treatment options that may be available for Howard. Let's first consider treatment options for the mass on his kidney. Dr. Sutka, what is cytoreductive surgery, and could that be an option to remove the mass?
So a cytoreductive nephrectomy is essentially doing a nephrectomy in the setting of us knowing that Howard or the patient has tumor in other organs or other places in their body. We used to recommend an upfront cytoreductive nephrectomy routinely in all patients with metastatic kidney cancer before they started medicine or systemic therapy. However, there was a big trial that came out that basically showed that with our newer treatments, the surgery plus the treatment alone was not better than just giving the systemic therapy. Now that changed a lot for how we think about treating metastatic kidney cancer. In this situation, we do think about removal of the kidney in certain circumstances, but in 2024, it's off because our systemic therapies are so much better. It's a little bit more of a nuanced discussion. We do think about an upfront cytoreductive nephrectomy in a patient who has excellent performance status, who has a small burden of disease elsewhere, and oftentimes in patients where the kidney is actually symptomatic. So for example, they might be having a lot of bleeding from the tumor or a lot of pain from the tumor. But those are rare circumstances. A lot of times these days, what happens is patients will go to see our colleagues in medical oncology first, receive therapy for their whole body with the hope of shrinking their tumor burden globally. And then if they have a good response and we start to see everything else kind of quiet down, that's when we do talk to patients about cytoreductive nephrectomy. We also, cytoreductive surgery actually also can include surgical removal of tumors elsewhere. So we can do cytoreductive, what is called metastasectomy, or removal of the metastases. So for example, if there's a dominant lung nodule and that's the only space that we see tumor in, they can go see one of our thoracic surgery colleagues and have that resected. If there's a metastasis in a weight-bearing bone, such as in the femur here, those patients might see orthopedic oncology and have that removed. And have a reconstruction, and that also can be helpful because those bones can be prone to fracture. So it's a very important and very sort of nuanced multidisciplinary discussion to think about what's going to be the best sort of sequencing of therapies for this patient who now has disease in a number of different places within their body.
Thank you so much. Now let's take a look at the masses on his lung and his femur. Dr. Hanan, could radiation be an option for either mass?
Yes, so there could be a number of roles for radiation for Howard or a patient like this that let me briefly go over. So the standard is palliative radiation, or radiation to prevent, to treat any pain or symptoms or bleeding, or prevent a bone fracture or weakening the bone further. So that could be applied to the bone metastasis here. So that's more the standard, and there is a few investigational setting. So similar to cytoreductive surgery, cytoreductive radiation is being investigated, where we would treat the kidney tumor in the setting of systemic or drug therapy in a trial called the Samurai trial. And then indeed, if the tumor has only gone to 3 spots in the body, that is what we will call the oligometastatic setting. And in that setting, stereotactic radiation is also being investigated in the SOAR trial. So those are investigational indications, but palliative and prophylactic indications are more standard.
Thank you. Dr. Kim, what about ablation? Could that be an option to treat either mass?
I think it depends on, primary mass is, it depends on size, but, lung is, it depends on size is, we able to treat the 3 or 4 lung nodules with ablation. We can try to, right rope pulse and then left rope kind of thing by rover, but is, some of the institutions, they treated 5, 6 nodules sequentially. And also is, if a tumor mass is bone mass, and then we can do ablation of the bone mass, and then also we can, inject the cement, prevention of in the future fracture. That's why, small size, small oligometastasis, ablation is a good options to either lung or bones.
Thank you, Dr. Kim. And lastly, Dr. Shup, could Howard have surgery to remove either the lung or the femur mass?
So, doing surgery is always a possibility, and we frequently ask our friend from maybe ortho-oncology to look at a bone lesion, or thoracic surgery to look at a lung lesion. But when someone has disease all over their body, and we're talking about palliation, I think we would try to offer things that might be less invasive, quicker recovery potentially first. If someone only had a single site of disease and we're trying to make sure that they really had the best option for local control, I mean, removing a site might be the highest rate of local success, but things like radiation, things like a percutaneous ablation, those are very effective and they have a much quicker recovery. So it's a multidisciplinary discussion about what is the best for the patient in that scenario.
Thank you. And finally, let's consider medications that could be used to treat Howard. Dr. McKay, can you talk about targeted therapy medications used to treat metastatic kidney cancer?
Absolutely. So targeted therapies, what we mean by that term is that they target a specific protein that's within the tumor cell that's more specific to the tumor cell. The classic drugs that have been utilized thus far have been what we call VEGF TKIs. So that's a vascular endothelial growth factor receptor. It's a receptor that's present on the kidney cancer cells. And when the drugs bind to that receptor, it prevents the receptor from working. That receptor helps when what's supposed to actually bind to the receptor binds to it, VEGF, it actually stimulates a cascade to cause the cancer cells to grow and flourish and make blood vessels and do other things. And so the targeted therapies are oral. Most of them are administered by mouth in a pill form. And they've really improved outcomes for patients with advanced kidney cancer.
Thank you so much, Dr. McKay. Dr. Fitzgerald, can you talk about immunotherapy medications that are used to treat metastatic kidney cancer?
Absolutely. So we've already discussed one briefly. Keytruda or pembrolizumab is an example of an immunotherapy. And these medications are given through the IV, and they work by blocking a molecular interaction between the cancer cell and the immune cell that allows the cancer cell to hide from the immune system. So I usually tell patients they can think of immunotherapies as treatments that allow the immune system to recognize and attack the cancer cells.
Thank you. There are many different medications that are approved to treat kidney cancer. Some may be preferred for clear cell RCC, while others might be preferred for other RCC types. You can see in the guidelines the different medication options and combinations. Dr. McKay, when would it be better to use one medication versus 2 medications to treat Howard's cancer?
Very good question. So, about a decade ago, 5 to 10 years ago, we used to treat newly diagnosed kidney cancer patients with single agent VEGF TKIs, those targeted therapies used as a single agent. And in 2018, the field really started to move away from that with a series of clinical trials that were conducted looking not just at using the oral therapies by themselves, but rather looking at combination therapies. Combination immunotherapy of using an immunotherapy doublet, such as nivolumab and ipilimumab. Those are two immunotherapy drugs, or taking the targeted therapy and doing it in combination with an immunotherapy. And so the field for clear cell RCC, because of lots of large phase 3 trials designed in clear cell RCC, have been conducted, have moved away from single agent TKIs to combination therapy. Now, the data for individuals with non-clear cell disease has lagged behind the data for clear cell RCC, though we have several single arm phase 2 studies looking at the activity of immunotherapy combinations with targeted therapies that have actually demonstrated efficacy in that group of patients. And actually, just at ESMO last week, we saw data of a randomized study for non-clear cell patients using combination therapy. So I think in general practice for an individual who's got papillary RCC that's metastatic, I do think that the field is shifting towards combination targeted therapy strategies for such an individual. And in a combination like nivolumab plus cabozantinib makes a lot of sense, given that cabozantinib, in addition to targeting VEGF, also targets another protein in the tumor called MET, which tends to be mutated or amplified in many papillary tumors. So I think we as a field need to continue to come together and design studies that are specifically for individuals that have variant histologies, so that we can continue to move the bar forward for those individuals.
So Dr. McKay, is there an ideal regimen for Howard with this case?
Yeah, if I had to pick a regimen, I would pick the combination of nivolumab plus cabozantinib for this individual. It's a doublet regimen, includes a TKI, and includes a TKI that's known to have activity for patients who have papillary RCC.
Thank you so much. Cabozantinib, a targeted therapy, is a preferred medication for RCC types that are not clear cell. Dr. Stevens, what are the possible side effects Howard may experience if he was given cabozantinib or another targeted therapy medication?
Certainly. Well, these drugs, like any others, can feel daunting when you look at the full side effects list, but keep in mind that we can often make these things manageable, either with supportive care or dose reductions. But the most common side effects are classically higher blood pressure and diarrhea. Some patients experience fatigue or weight loss. Pain or sores in the mouth can occur, as well as peeling on the palms of the hands or soles of the feet. These therapies also impair wound healing, so it's important for patients to let us know about invasive procedures and surgeries, because we usually need to have patients off of treatment for a while around the procedure to allow for adequate healing.
Thank you. Another question, Dr. Stevens. Are the side effects different if Howard receives a targeted therapy plus an immunotherapy combination regimen?
I think of IO and VEGF TKI combinations as a Venn diagram. So you get the possible side effects of each drug, and then there's some side effects that can overlap between the two. The most problematic ones, and the ones I see the most commonly, are diarrhea and liver function abnormalities. It's really important for us to be very aware of when patients are experiencing these things, so we can quickly identify which drug is causing it, because causative drug really affects how we manage these side effects, and it can be really tough to tease out sometimes.
Thank you so much, Dr. Stevens. Clinical trials may be a good option for Howard as well. Dr. Fitzgerald, can you discuss some current clinical trials for metastatic kidney cancer that are evaluating new medication options?
Yes, definitely. And first, as Dr. McKay already told us, one of the challenges in trials for non-clear cell kidney cancer is being able to find enough patients that have these rare subtypes of the disease. And many of the studies that have already been done are kind of grouping all of these patients into one category, when really the goal that we have as a field is to try to move towards doing studies for patients with individual kidney cancer subtypes. So we really understand what is the optimal treatment approach for each of those. So this list is clinical trials for patients with non-clear cell. If we did all of kidney cancer, that would be a presentation in itself. And so the trial at the top, Stellar 304, is a study where a novel targeted therapy, XL092, in combination with nivolumab, is being randomized versus a targeted therapy called sunitinib in patients with non-clear cell kidney cancer. The next two on this list, the SYMETA trial and the PAPMET-2 trial, are both kind of getting at this question of disease-specific and molecularly specific histologies, where they're looking at novel treatment combinations in patients specifically with papillary kidney cancer that is felt to be driven by a signaling molecule called MET. And then the final trial here, the CANI trial, is investigating a triplet combination, so a targeted therapy with cabozantinib in combination with 2 immunotherapy drugs, again in patients who broadly fit the category of non-clear cell renal cell carcinoma.
Thank you, Dr. Fitzgerald. There are some clinical trials that are evaluating using radiation therapy to treat metastatic kidney cancer. Dr. Hanan, could you discuss those trials?
Yes, I briefly mentioned them. So the first one is the Samurai trial. This is actually Rana McKay. Dr. McKay is one of the PIs. It's investigating cytoreductive nephrectomy with radiation in the setting of metastatic cancer in combination with checkpoint inhibitors. And I believe a number of histologies are allowed in this trial. The second trial is the SOAR trial. This is the one with oligometastatic kidney cancer, when the kidney cancer has spread to a limited number of places, mainly 2 to 5 sites of disease, and patients will be randomized to receive stereotactic radiation first, followed by the drug therapy versus upfront drug therapy. And our hypothesis here is that we think for patients that have slower progressing cancer, we can delay safely the systemic therapy, and by doing that, give patients good quality of life by controlling the cancer with just radiation and sequential radiation for a number of times. And in our earlier phase 2 studies, we have shown that we can control the cancer for about a year or 2. So these are the 2 trials that are investigating the application of stereotactic radiation in the setting of metastatic kidney cancer.
Thank you, Dr. Hanan. That concludes case 4, and it also concludes today's panel discussion. A big thank you to our panelists, Dr. Fitzgerald, Dr. Gordetsky, Dr. Hanan, Dr. Kim, Dr. McKay, Dr. Sukkah, Dr. Shutt, and Dr. Stevens. We hope that you found this session interactive and informative, and that you have a better understanding of how doctors and clinical teams make decisions with real-life kidney cancer cases. Thank you so much.